Okay, the second lesson under hematologic agents are the drugs used for dyslipidemia. In this portion, we will talk about the agents that are being used in different disorders affecting lipid levels. So the topic outline on this lesson are: number one, we will review what are lipids. Of course, you have already an idea what are lipids based on our lecture in biochemistry before. Second are the lipoproteins. Third would be physiology of handling lipids, meaning paano ba minemetabolize ng katawan natin ang lipids, paano siya nabe-breakdown kasi drugs can alter those metabolic processes. After which, we will proceed on the treatment goals. What are the pharmacological and non-pharmacological goals in the management of dyslipidemia? And then finally, the specific drugs. Before I officially start, masyado ba nakaka-interfere yung electric fan or okay lang siya? Hindi ba distracting? Okay lang, sige, thank you. So going back to lipids, recall class, when we discuss lipids in biochemistry, these are biological molecules that are basically insoluble in water. Okay, these are basically insoluble in water, and they are said to be soluble in organic solvents like oils. So yun lang yung major determinant natin para malaman na ang structure ay isang lipids. And remember, based on their susceptibility to certain agents like enzymes, we can classify lipids into either hydrolyzable and non-hydrolyzable, right? Na-discuss natin to before, in which hydrolyzable lipids are the ones that are susceptible or vulnerable to certain agents, particularly enzymes. Since ang pinag-uusapan natin ay sa loob na ng katawan, we will focus on the enzymes that can hydrolyze lipids. And the enzymes that can hydrolyze lipids inside the body, these are called as lipoprotein lipases. Okay? Again, ang tawag sa enzymes sa yon ay mga lipoprotein lipases. Particularly, the hydrolyzable lipid present in the body that can be hydrolyzed by these enzymes are the triglycerides. Okay? Triglycerides. Note class, triglycerides are esters, as you remember before. Okay? These are esters in which once hydrolyzed by the LPL are the lipoprotein lipases. Okay? In which kapag na-hydrolyze ng lipoprotein lipases, na-form ang products free fatty acids and also glycerol. Okay? Again, these are free fatty acids and also glycerol. So yan ang example natin ng hydrolyzable inside the body. Whereas we also have non-hydrolyzable. Non-hydrolyzable lipids, these are the ones that even in the presence of lipoprotein lipase, hindi ito na-breakdown or hindi ito nakakatabolize. Ang example natin ng non-hydrolyzable lipid is cholesterol. Okay, cholesterol. Basically, ang cholesterol contains a steroidal nucleus. Kaya nakalagay dyan, isa siyang steroid. And that steroidal nucleus has 4 rings. Diba? Meron siyang 4 rings na structure. So yan, basically, ang dalawang types ng lipids na may kinalaman sa discussion natin. Okay? Now, how can we relate lipids inside the body with the so-called lipoproteins? Paano natin siya i-connect? Remember, as we discussed, lipids are insoluble in water. When we relate water inside the body or aqueous solutions inside our body, ang related dito ay ang blood. Okay, ang blood. Now, when we talk about the blood like the plasma, just like water, aqueous siya in nature. So anong importance ng pagsabi natin na aqueous ang blood? Since the blood is aqueous in nature, we tend to conclude that lipids cannot mix well with the blood. So lipids do not mix well with the blood. Now, kung ang lipids being insoluble in water and also in the blood, which is aqueous, ano ang implikasyon niyan? So kung hindi humahalo homogeneously ang lipids sa dugo, mahirap i-transport ang lipids sa iba't ibang parts sa katawan. The blood will find it hard para i-distribute ang lipids sa iba't ibang peripheral tissues or in the different parts of the body. Okay? So now, to be able to solve, this problem, para ma-transport pa rin ang lipids despite of their insolubility with the blood, lipids have to be combined with proteins. Again, ang remedy o ang solution natin to be able to transport lipids together with the blood is dapat magdagdag tayo ng protein with the lipids. Okay? So magdagdag dapat tayo ng proteins with lipids. Ang proteins, very diverse ang kanilang actions inside the body. And one of the functions of proteins is to facilitate transport of substances, okay? To facilitate transport. And one of the compounds that they transport are the lipids. So in Tagalog, ganito siya kasimple, para ang lipids sumama pa rin sa dugo, kailangan i-assist sila ng proteins. Okay? I-assist sila ng proteins. So with that, pag pinagsama natin ang protein component at yung mismong lipid na ita-transport, meron tayong tinatawag na lipoproteins. Okay? That's why we have the term called lipoproteins. When we say lipoproteins, these are the combination of the lipid portion, na kailangan i-distribute at kailangan ma-utilize ng ating katawan, and the proteins that serve as the transporters or the assistants para makisama pa rin ang lipid sa dugo na aqueous. Do you understand the essence of adding proteins to lipids? Okay, so the importance is to facilitate transport. That's why we have the term called lipoproteins. So with lipoproteins, as we said, ito ay nilalaman ng lipids at proteins. In particular, ano ba ang mga lipid components ng lipoproteins? Kindly note, class, that the lipid components are the ones that were put in bracket. Okay? Again, are the ones that were put in bracket. So these are the tags or the triacyl glycerols. Next, we have cholesterol esters, the phospholipids, and the free cholesterol. Whereas, ang apoproteins, ito rin yung protein portion. Yan yung tawag sa protein portion ng lipoproteins. So I repeat, the ones that were put in bracket, these are the lipids. And finally, apoproteins, ito yung protein component or protein composition. Now, let's focus on the apoprotein component. Let me tell you, class, na aside from the transport per se, apoproteins are important for the following reasons or following purposes. Number one, ang apoproteins, these are responsible for the structural stability of the lipoproteins. Again, important siya for the structural stability of the whole lipoproteins. And then second, it can act as ligands. Again, or they can act as ligands. Apoproteins serve as ligands para kapag ang lipoprotein ay nakipag-interact with the receptor, there could potentially be a ligand receptor interaction causing transduction process. Okay, so ligands. And then finally, pwede sila mag-act as cofactors. Okay? Apoproteins could act as cofactors during enzymic reactions. So these are the functions also of apoproteins aside from facilitating transport. So number one, we have structural stability. Second, ligands. Third, we have cofactors. Now, kindly refer everyone on the figure found on the right side. Take note that this figure represents the lipoprotein. And then, yung color violet one, again, the color violet, it represents the apoprotein portion. Okay, apoprotein. Now, kapag chinek natin, dinisect natin ang itsura ng lipoprotein, meron tayong makikita sa internal region and on the surface. Again, meron sa internal and also meron sa surface. Number one, yung internal, okay, letter I means internal. In the internal environment, we can see the following. Number one, we have cholesterol ester. Again, number one, we have cholesterol ester. And aside from the cholesterol ester, internally found as well are the tags. Again, internally found also are the triacyl glycerols. Triacyl glycerols, by the way, before I forgot, triacyl glycerols are also your triglycerides. Ay synonymous lang sila. Para pag binanggit ko siya mamaya, di na kayo malilito na magkaparehas lang pala ang TGs and tags. Going back, in the internal, we have cholesterol ester and also triacylglycerols. Next, what about in the surface? So ano naman yung mga makikita natin sa surface ng lipoproteins? Number one, in the surface or externally found are the apoprotein. Okay, number one, we have the apoprotein or the protein portion. Second, we have the phospholipids. Okay, again, second, we have the phospholipids. I repeat, we have apoprotein, phospholipids, and finally, we have unesterified cholesterol. I repeat, we have apoprotein, second, phospholipids, and then finally, we have unesterified cholesterol. Guys, take note that unesterified cholesterol is also your free cholesterol. Okay, again, that is also your free cholesterol. So yan yung mga locations ng mga components ng lipoproteins. So i-check natin sa figure kung tama yung nakalagay. Number one, sa internal o sa loob, we have the cholesterol ester. Kaya makikita nyo, nakaturo siya sa loob kay cholesterol ester. And then triacylglycerol could also be found internally o sa loob. Whereas in the surface, we have the apoprotein. Ito ang represent sa apoprotein, which is embedded in the surface. Embedded siya. And then the phospholipid, ito siya, nasa layer din. And then finally, the unesterified or the free cholesterol, nasa surface siya. Okay? So yan yung mga locations ng mga components ng lipoproteins. Nasusundan? Okay. So since we were able to discuss what are lipids and then what's the importance of converting lipids to lipoproteins, let's talk about the different types of lipoproteins. We can differentiate the types of lipoproteins depending on their density, and also their functions. Now, pag diniscuss natin ang different types of lipoproteins, yung mga terminologies ng pangalan nila ay may kinalaman sa density of flotation. Okay, density of flotation. So number one, we have chylomicrons. Second are the VLDLs. Third are the IDLs. Then we have LDL and HDL. This is no longer new to you because we were able to touch this briefly in biochemistry. So ngayon, konting elaboration ang gagawin natin. This figure summarizes the different classes of lipoproteins in which you can see that the largest are the chylomicrons. Okay, pinakamalaki in terms of size are the chylomicrons. Pero they have the smallest density of flotation. Okay? So siya ang may pinakamababang density of flotation, and then we have the very low density, intermediate, LDL, and HDL. Guys, iisa-isahin natin sila beginning with chylomicrons. So when we talk of chylomicrons, these are the largest in terms of size, but in terms of density of flotation, these are the smallest. Okay? So sila may pinakamaliit na value ng density of flotation. When we talk of the structure of chylomicrons, on top of the apoprotein present are the triglycerides. In fact, majority of the contents na makikita sa chylomicrons, triglycerides. Recall, ano ba ang mga triglycerides? Are these hydrolyzable or non-hydrolyzable? As we remember, so sabi natin these are hydrolyzable. Meaning to say, these lipids can be hydrolyzed by lipoprotein lipase. Meron siyang impact later sa mga succeeding discussions natin. And then ang chylomicrons, these are the ones that originate from the intestine and nanggagaling siya o napoproduce siya from the exogenous dietary fat. Ibig sabihin, chylomicrons are being formed from the meals that we eat, okay? From the food that we take. So remember, when we eat food, when we eat meals, syempre dadaan siya sa GI tract and then eventually makikita siya sa small intestine. So manggagaling sa small intestine ang chylomicrons. And then after that, the triglycerides that they possess or that they contain will be transported into the bloodstream. Okay, from the small intestine through chylomicrons transport ang triglycerides and other lipid contents into the blood. Now, please note that for the transport of chylomicrons to happen, again, para mangyari ang transport of chylomicrons, we actually need a protein carrier, or what we can describe this as transporter. Okay? So ang tawag natin sa transporter that facilitates transmission or transport of chylomicrons into the blood is the NPC1L1. Okay, again, ang tawag doon ay NPC1L1, and this stands for Niemann-Pick. Okay, this stands for Niemann-Pick. Okay, Niemann-Pick C1 like 1 transporter. Again, this means Niemann-Pick C1 like 1 transporter. Through this protein or through this gate somehow, makakatawid ang chylomicrons into the blood, kaya ready na siyang i-distribute or ready na siyang i-circulate. That is the function of Niemann-Pick C1 like 1. Please remember this transporter because mayroong related drug that can block that. Okay? May related drug that can block that. Moving forward are the VLDLs or the very low density lipoproteins. Now, ang similarity, again, ang similarity ng VLDL at ng chylomicrons kanina, majority ng content sila TGs or triglycerides. Major composition of this both lipoproteins, we have the tags or triglycerides. However, yung pinanggalingan, okay, yung origin ang difference. Ang origin ng chylomicrons ay exogenous, meaning to say, galing sa pagkain kinain natin. So from the small intestine. That's for chylomicrons. Whereas for VLDL, ito ay endogenous. Again, ang VLDL naman ay endogenous. That is, VLDLs are being synthesized by our liver, and being transported mula sa liver into the blood. So ito naman, liver going to the blood. Okay, liver going to the blood. That's the difference between the chylomicrons and also VLDL. Pero anong similarity nila? Ano ang dominant composition nilang dalawa? What type of lipids? Triglycerides. Okay, so triglycerides. So tandaan yan, meron siyang connection later. And then also pakitandaan na ang protein composition, again, the protein composition or the apoprotein composition of VLDLs is the ApoB. Okay, ApoB. So ang tawag doon ay ApoB or apoprotein B. May kinalaman siya sa drugs later, so stay tuned. Tandaan nyo muna pag VLDLs, ang apoprotein component ay tinatawag na ApoB. Next, we also have intermediate density lipoproteins. Basically, ang intermediate density lipoproteins, ito ay VLDL remnants. Again, these are VLDL remnants. Tira-tira ng VLDL after makatabolize ng VLDL. Okay? And intermediate density lipoproteins are the ones that are found in the middle between the VLDL and LDL. So later when we summarize this all together, kailangan maalala natin na ang IDL nasa pagitan ng catabolism of VLDL and LDL. Magiging realistic siya mamaya. Okay? And then, nasabi natin na VLDL remnant siya after catabolism of the triglyceride portion of the VLDL. So you can see that the average triglyceride content of IDL is less. Okay? This is actually less than the triglyceride composition of the VLDL, which is from 50 to 70%. Kaya nga remnants, kung ano yung natira sa VLDL after catabolism. Okay? Next, we have low-density lipoproteins or LDL. Tandaan for LDL, this is composed mainly of cholesterol. Again, this is mainly composed of cholesterol. In other words, in LDL, negligible na ang amount ng triglyceride. Okay? So, negligible na ang amount ng triglyceride. So, I repeat, in LDL, majority cholesterol ang meron. Okay? Cholesterol ang meron. And then, halos ubos na ang triglycerides. Now, ano ba ang nagiging fate ng LDL sa ating katawan? Again, ano ba ang nagiging fate? Of course, ang LDL ay pumapasok sa cells natin. Okay? Pumapasok sa cells via receptor-mediated endocytosis. So you learned before that ang endocytosis is the process of vesicular transport into the cell. So ibig sabihin, vesicle form siya papasok sa loob ng cell. So ang LDL pumapasok sa loob ng cell through vesicles. Okay, kabaliktaran siya ng exocytosis last time. Now, anong klaseng cells ang pwede niyang puntahan? Okay, anong klaseng cells ang pwede niyang puntahan? Number one, as written in the PowerPoint, napupunta siya sa liver or in the hepatocytes. Again, in the hepatocytes, there is receptor-mediated endocytosis. So with that, we can expect na since ang LDL, they contain many cholesterol, tumataas ang cholesterol amount into the liver. Okay? Tumataas ang cholesterol level inside sa loob ng liver. What's the importance of this? Ang cholesterol, once increased in the liver, this serves as a precursor in the synthesis of bile acid. Okay? Bile acid synthesis. So important ang cholesterol for bile acid production, because the liver can produce bile acids. Okay? So una, in the hepatocytes, increase in cholesterol in the hepatocytes can induce bile acid synthesis. And then also, in the peripheral tissues, pangalawa, in the peripheral tissues or peripheral cells, pwede rin magkaroon ng receptor-mediated endocytosis. During receptor-mediated endocytosis in the peripheral cells, syempre, nagkakaroon din ng enough cholesterol supply, nagkakaroon din ng enough cholesterol supply sa mga cells natin. This is also important. Why? Please note that cholesterol is a steroid and that serves as a raw material. Okay? This serves as a raw material or a precursor para makagawa ng iba't ibang substances like steroid hormones. So important ang cholesterol para makagawa ng steroid hormones, kagaya ng cortisol, kagaya ng aldosterone, sex hormones, lahat yan na regulatory hormones sa katawan galing sa cholesterol. Kaya our cells need cholesterol, okay? As very apparent. Next, aside from that, important din ang cholesterol sa peripheral cells, lalo na sa stability ng cell membranes. Okay, stability of cell membranes. So important din ang cholesterol in providing stability of the cell membrane. So basically, cholesterol in the peripheral tissues are important. Okay, cholesterol is very essential for the production of steroid hormones and stability. However, all of these processes are essential in the body. Ang tanong, paano kapag excess na siya? Okay, paano kapag excess? When we say excess, simply, kapag there's too much for bile acid and there's too much for steroid and stability, pwedeng hindi na ma-accommodate ang cholesterol by these cells. Okay, pwedeng hindi na nila kayanin. Kaya chances are, this excess LDL pwede maligaw ng landas. Pwede sila mapunta somewhere na hindi dapat sila mapunta. So that is, pwede sila mapunta sa arteries pag sobra. Okay? Kapag sobra, they could be deposited in the arteries, and when it happens, it can cause oxidation, oxidation of the LDL via the macrophages. Okay? Via the macrophages. So they may undergo this LDL na naligaw, na napunta sa arteries, especially pag excess, they may undergo oxidation via macrophages, causing calcification. Okay, causing calcification. In Tagalog, pwedeng tumigas yung cholesterol na na-deposit sa arteries. Do you think, nasa-sense nyo ba na pwede makasama ito sa arteries pag tumigas ang cholesterol sa arteries? Yes, of course. Remember, arteries are designed to be elastic para pag may changes in blood pressure, pwede siya maka-adjust. So pag nagkaroon ng calcification, eventually magkaka-plaque formation in the arteries that could make arteries rigid. That's why arteries will find it hard to adjust in terms of changing pressure. So kapag hindi siya maka-adjust sa pagbabago sa pressure, doon na pwede mag-emerge ang iba't ibang cardiovascular diseases. Okay? So yan ang fate usually ng LDL. So usually sa hepatocytes and peripheral cells, but excess of such can cause accumulation in the arteries, causing atherosclerotic plaque. Okay? Pwede magkaroon ng calcification. So, dyan din natin maiko-connect yung description about LDL na siya ay isang bad o isang good cholesterol. Based on our discussion, siya ay isang, sa LDL muna, L. Yes, very good. So, dyan natin ma-realize na ang LDL ay isang bad cholesterol kasi ang LDL, kapag may sobra siya, it takes away cholesterol para mapunta sa mga blood vessels like arteries. Ang kabaliktaran ng kabaliktaran ng LDL rather ay HDL. Ang HDL ay isang good cholesterol because ang major objective lang niya dalhin ang cholesterol back into the liver. Yun lang. Okay, yun lang. Wala siyang kakayahan, take note, ang HDL, wala siyang kakayahan na dalhin sa peripheral cells ang cholesterol. Unlike LDL, okay? So wala siyang kakayahan yan. Wala rin siyang kakayahan na kahit sumobra pa ang cholesterol, wala siyang kakayahan dalhin sa arteries. Which is good. Kasi ang kaya lang niyang gawin ay instead ibalik sa hepatocytes or ibalik sa liver. So that's why we deem HDL as protective lipoproteins, and this may result from participation of LDL in reverse cholesterol transport. Reverse, ibig sabihin, anong sabi natin pag may excess cholesterol pag reverse? Is it papuntang arteries or away from the arteries kung reverse transport? Yes, it's away from the arteries. So you expect na if it's away from the arteries, pabalik siya instead to the liver. Okay? Kaya may mga drugs na ang goal pataasin ang HDL, which is a good thing. So remember, ang good cholesterol ay ang HDL. Di ba ang diniscuss natin before dito, palatandaan nyo dyan is ang HDL, H-halika cholesterol halika. So isipin nyo ang nagsasabi ng halika cholesterol, liver. Okay, liver. So kung halika cholesterol halika, what will you conclude? Palapit sa liver. Okay? Kapag naman LDL, we are talking here about the excess cholesterol. We are talking here about the excess cholesterol. So ang LDL, L, layo, cholesterol, layo. Yun ang sinasabi ni liver. So kung layo, cholesterol, layo, edi palayo yun papuntang arteries. Kaya nga, conveys lipids into the arterial wall. And then HDL, good cholesterol. Okay? So overall, these are the different types of lipoproteins. O recap tayo, class. Kapag sinabi nating types ng lipoproteins, chylomicrons ay highest density or lowest density of them all. Pag chylomicrons, lowest density. In terms of size, largest or smallest, chylomicrons, very good largest. And then, ano mapapansin sa chylomicrons at VLDL? Pinakamarami ang triglycerides. Okay? Ano lang pinagkaiba ng VLDL at ng chylomicrons? Origin. Okay? Pinanggalingan. Sino sa dalawa ang galing sa small intestine? C of V. Very good, C. Ang galing sa liver ay C, VLDL. Sino ang endogenous? C of V. Very good, V. Anong tawag kay chylomicrons? E di, exogenous. Okay, very good. Exogenous ang tawag. Now, ano naman ang pinagkaiba ng LDL at HDL? Ang pinagkaiba yung process of transporting excess cholesterol. Kasi kapag transport of excess, halika, palapit ng liver, LDL, layo. Okay? Layo cholesterol. Papunta sa arteries. Okay? So taken all together, those are the types of lipoproteins. Now, pag sama-samahin natin lahat yung diniscuss ko by discussing this figure. This picture is no longer new to you as well kasi na-discuss natin ito sa biochemistry. So i-recap lang natin based on your learnings, again based on your learnings sa mga types ng lipoproteins. So this picture is divided into two segments. Number one is the exogenous pathway, meaning galing sa kinain nating pagkain, and then endogenous sa loob na ng ating katawan. Okay? Kung saan nag-originate yung mga lipoproteins na ginagawa. So suppose, kumain tayo ng pagkain and then the food was digested by the small intestine. Now, the lipid component, are you still listening by the way? Okay, so the lipid component, anong sabi natin? Is it easy or hard for the blood to transport lipids? It's hard, right? Kaya ang gagawin is, in the small intestine, the lipid component will be combined with the apoprotein composition. Anong sabi natin pag apoprotein? The protein part, di ba? Important siya. So that is in the small intestine, we have the chylomicrons already. And para makapasok ang chylomicrons sa capillaries or in the systemic circulation, di ba meron tayong transporter na kailangan? Anong tawag natin sa transporter? Mahabang pangalan yun, di ba? It starts with letter N. Ngayong Niemann-Pick, C1, like 1. Okay? So suppose, nakapasok na ang chylomicrons into the capillaries, during transport, chylomicrons will meet lipoprotein lipase. Are lipoprotein lipases hydrolytic enzymes? Are they hydrolytic enzymes? Yes. So that's why the triglyceride component will be cleaved off. Matatanggal siya. Anong product natin pag na-hydrolyze ang triglyceride? Free fatty acids. Okay, free fatty acids. And in this case, ang free fatty acid will be catabolized eventually by the adipose tissues. Now, you can see that the size of the chylomicrons diminishes. Lumiliit siya. At ang lumiit o natira ay mga remnants, mga tira-tira. Question, ano tong mga tira-tira o ano tong mga remnants? Ang mga remnants na yan, ito yung hindi na hydrolyze ng lipase. Ay, ito yung mga hindi na hydrolyze. Halimbawa, syempre proteins. Yung proteins o yung apoproteins, hindi naman siya na nakakatabolize ng lipoprotein lipase. Kaya matitira siya. Remnants ang tawag doon. Ano pa? Sa tingin nyo, cholesterol matitira dito? Yes or no? Sa tingin nyo yung cholesterol parte ng remnant? Yes or no? O sige, guide ko kayo ha. Ang cholesterol ba ay hydrolyzable o non-hydrolyzable? None. Very good. So kung makikita sila ng lipoprotein lipase, may effect o wala? Kung makikita sila ni lipase, yes, walang effect yun. Resistant ang cholesterol from hydrolysis. That's why parte ng remnants yung cholesterol component. Okay? So what happens next? The tira-tira or the remnants of chylomicrons will be uptaken by the liver via endocytosis. Okay? The remnants will be uptaken through receptor-mediated endocytosis. Now, so far ang na-discuss natin, exogenous, hanggang makapasok sa liver yung mga natira sa chylomicrons. What will the liver do? The liver will convert or will ano bang tawag dun sa pag-transform? O yun, pwede na yung transform. Will transform, will make up, kaya pwede niyang i-improve yung remnants para ma-convert back siya in such a way na maraming triglycerides. So dadagdagan ng liver ng triglyceride portion yung remnants. And when the time comes na nadagdagan na ng triglyceride portion yung remnants, ready na niya ulit ilabas iyon. Okay, ready na niya ulit ilabas. At ang nilabas niya eventually ay VLDL na. Okay, VLDL. So somehow, nagkakaroon ng sense dito yung mga diniscuss ko kanina. Remember, ang VLDL, marami bang TG sa VLDL? Yes or no? Marami bang triglycerides ang VLDL? Yes. So bakit siya marami? Dinagdagan ng liver. Okay, dinagdagan ng liver. And then, anong sabi ko? Saan galing ang VLDL? Galing sa liver, di ba? And then, part siya ng endogenous pathway na. So, after release of VLDL by the liver, makakapasok ulit siya into the capillaries and then will be hydrolyzed once again by the lipoprotein lipase, thus extracting the free fatty acid composition for tissue utilization. And then, smaller version of the lipoproteins are the IDL. Kaya nga, guys, anong sabi ko kanina? Ang IDL ba ay VLDL remnants? Dun sa discussion natin kanina? Yes or no? Yes. Tira-tira siya ng VLDL kasi natapyas ang isang portion ng VLDL na triglycerides. Natanggal na-cleave off. So therefore, ang IDL, when you check your notes, may triglyceride composition siya but less than the VLDL. Okay? Less than the VLDL. And then, continuous exposure of IDL to lipoprotein lipase will continuously remove triglycerides until such time na ang matitira ay LDL na lang. What did I tell you about LDL, guys? Ang LDL, ano na lang ang laman ng LDL? Ano na lang ang laman niya? Cholesterol. Very good. Cholesterol na lang ang laman. What did I tell you? Ano ang fate ng LDL? Ano usually ang fate ng LDL? May LDL ba na pumapasok sa liver through endocytosis? Yes or no? Yes. Anong purpose ng pagbalik ng cholesterol or ng LDL containing cholesterol into the liver? Upang makapag-produce ng bile acids. Okay? Para makapag-produce ng bile acids. What else? Pwede ba makarating ang LDL sa peripheral or extrahepatic tissues or sa peripheral cells? Pwede ba ito? Yes or no? Yes. Anong importance para makapag-produce ng certain compounds like letter S? Ano yung S? Mga steroidal hormones. Yes, that's good. And then, importante ba siya sa cell membrane natin? Yes. So that's why nabanggit natin na may napupunta sa liver, may napupunta sa extrahepatic tissues. Suppose may sobrang LDL containing cholesterol. Pag may sobrang LDL containing cholesterol, pwede pumunta sa letter A. Anong tawag sa letter A? Arteries. Is it good or bad? Bad. That's why meron tayong savior in the form of HDL. Ang HDL, cholesterol din ang laman niya, pero the process of transport ang pinagkaiba. In short, kapag HDL, binabalik niya eventually ang excess cholesterol into the liver, which is a good thing rather than ma-deposit into the arteries. Okay? By the way, before I forgot, please remember that the apoprotein components of HDL are these ones. ApoA1 and ApoA2. Very important siya kasi may drugs na nag-act by modifying or by altering the level of these apoproteins. Okay? So for HDL, we have ApoA1 and ApoA2. Parang nabanggit ko rin yung sa VLDL, di ba? Naalala niyo yung VLDL, ApoB? Naalala niyo yung ApoB kanina? So nabanggit din natin siya earlier. Okay? Connected siya sa mga drugs. So yan ang figure showing to us physiology of handling lipids. So if this is not yet enough for you or for us, another way of explaining it is by having this figure. Actually, yung tatlong figures dyan, paulit-ulit lang yan, pero same thought. Okay? Para lang ma-reinforce. O ganito siya, ulit, para ma-reinforce. In the intestine, ano magagawa? Chylomicrons. Ang chylomicrons, by the way, nasusundan pa ba ako? Ha? Okay. So intestine, chylomicrons, exo or endo? Exo. And then, LPL, enzyme ba tong LPL? Yes. Anong matatanggal? TG or cholesterol? Anong matatanggal? TG or cholesterol? Pag may LPL? TG or cholesterol portion? TG, right? Kaya may free fatty acid. for tissue utilization. So may chylomicron remnants. Anong susunod na mangyayari sa chylomicron remnants? Ipapasok saan? Ipapasok sa liver. Okay? Anong gagawin ng liver? I-make over niya ba? I-make over niya ba yung chylomicron remnants? I-improve niya ba yung chylomicron remnants? Yes. Okay? Anong idadagdag niya? Siyempre yung nawala. Ano ba yung nawala kanina kay chylomicrons? Triglycerides. That's why magdadagdag siya, kaya ready na niya ulit ilabas yon. Ano na ang product pag nabago na niya yung remnants? VLDL na. Pag VLDL, endo or exo? Endo. Ano yung apoprotein component niya? Anong letter? A, B, C, D. Anong letter? B. Right. And then, LPL na naman, IDL na naman, hanggang LDL. What did I tell you pag LDL? May napupunta sa peripheral tissues at may bumabalik saan? Sa liver. Kaya lang pag sobra nga, ay kapag sobra, ano mangyayari? Mapupunta sa arteries. Okay, very good. O isa pa, para ma-reinforce lalo. So ganun din ito, paulit-ulit lang. Meron lang tayong endogenous at exogenous ulit. O ganun ulit siya. Kain, pagkain, intestine, chylomicrons. Pagpunta sa bloodstream, merong lipoprotein lipase. Hindi lang pinakita rito, pero yung point ng triglyceride in the form of free fatty acid. In the form of free fatty acid. May tira-tira, chylomicron remnants. Okay, chylomicron remnants. Panoorin nyo na lang ha, para ma-reinforce na yung discuss natin kanina. Ipapasok sa liver or hepatocyte. Okay, papasok sa liver. So ang gagawin ng liver, magdadagdag ng triglycerides, i-make over nga yung remnants, kaya ilalabas ulit siya in the form of VLDL. Okay? And then lipoprotein lipase again, matatanggal ang free fatty acid, mababawasan. Are you learning? Nasusundan? Okay. And then IDL, very good, IDL, eventually LDL na lang. O for the nth time, anong laman ng LDL? Is it TG or chole? Chole, that's right. Ilan ang fates ng LDL? Ilan ang fates ng LDL? Ilan ang kinakahinatnan niya? Tatlo, di ba? Tatlo. Una, babalik sa liver. Pangalawa, pupunta sa cells. At pag sobra, anong sabi natin? Pag sobra, pupunta saan? Arteries. Saan siya makikipag-interact? Sa macrophage. Okay, sa macrophage. Kaya ano nangyayari? Oxidation or reduction of lipid-laden macrophages. Ano mangyayari? Oxidation. Kaya magkakaroon ng plaque formation. Yan yung sinabi ko kanina. Hopefully via this figure, mas na-connect yung mga diniscuss natin about lipoproteins. And finally, nabanggit natin also that pag may excess cholesterol, thank God meron tayong HDL, because basically ang HDL, it carries also cholesterol, but it carries cholesterol back into the liver. Kaya meron dyan direction, pwede muna siyang dumaan into LDL in some cases and then ibabalik into the liver, and then pwede rin into IDL. Pero in short, para madali nyo matandaan, pabalik sa liver. Yun lang ang gagawin ng HDL. Wala nang iba pa. Okay? Overall, that's the end of physiology of handling lipids. Naintindihan? Were you able to connect lipoproteins with the process itself? Okay, so that's good. So natapos natin i-discuss ang physiology of handling lipids. Now, since we are having pharmacology as our course, we have to recognize first the disease that will be addressed by drugs. Kaya everyone, magfo-focus tayo sa parting ito. Okay, sa parting ito na kung saan ang lipid-laden macrophages ay nagiging plaque, ay nagka-calcify siya. Kasi dito eventually magkakaroon ng mga certain pathologies that would affect person's health. Okay? Risk factor din kasi pag mataas ang lipid levels. Okay? Yung other parts kasi, usually normal naman siya or hindi ganun ka-common yung mga sakit associated with them. So recall that cholesterol is a non-hydrolyzable lipid that when accumulated, pwede siyang mapunta sa mga unwanted areas of the body, lalong-lalo na sa arteries. And in the arterial walls, it could undergo oxidation, thus pwede magkaroon ng plaque buildup. Ulitin natin, ang consequence, kapag nag-accumulate ang cholesterol here, pwede siyang manigas, pwede siyang tumigas, making the arteries rigid. Okay? Pwedeng tumigas din yung arteries. So try to imagine, pag matigas ang arteries, it cannot adjust whenever there are changes in the blood pressure. Question, ang blood pressure ba natin ay laging nagbabago whenever may kakaibang stimulus outside? Yes, di ba? Kaya nga meron tayong compensatory mechanisms like baroreceptors and RAAs. Now, pag ang arteries ay hindi makasabay sa mga changes na yon, that could lead to certain diseases like hypertension. What else? Ano pa ang nakikita nyo sa figure na to? Kapag may accumulation of fats here, how's the diameter of the artery? Is it wide or narrow? Of course, it's narrow. Di ba? Makitid siya. Meron bang posibleng sakit na pwedeng mai-associate kapag ang arteries ay masikip? Halimbawa, coronary arteries? Yes, di ba? Anong posibleng sakit ang mangyayari? Anong posibleng sakit? Naalala nyo sa angina yung coronary artery disease? Can you recall this? Yung coronary artery disease, yes. So isang cause ng coronary artery disease ay atherosclerosis, right? Which is characterized by hardening of fats or cholesterol into the walls. So that is coronary artery disease. So related pa rin sa accumulation of cholesterol. So what are we trying to establish here? Ano yung implikasyon pag sobra ang cholesterol? Nasosolusyonan ng gamot later. Okay? What else? Ano ba ang posibleng, or ano ba ang posibleng reason kung bakit tumataas ang cholesterol sa tao? So number one, you have to note that ang katawan natin, particularly the liver, it can produce its cholesterol by itself. Okay? It can produce cholesterol by itself. Ang tawag doon ay de novo cholesterol synthesis. So ang tawag doon ay de novo cholesterol synthesis. So let me tell you, dun sa left side ng figure, kaya may picture dyan na liver because our liver can produce its own cholesterol, de novo. So ang de novo cholesterol biosynthesis, i-discuss natin briefly ano ba yung pathway involved. Okay? Ano ba yung pathway involved? So basically, ang pathway involved dyan is yung compound called acetyl-CoA, which is the common product of catabolism, di ba, in biochem. Ang acetyl-CoA, this is being catalyzed by HMG-CoA synthase. Okay, this is being catalyzed by HMG-CoA synthase, forming HMG-CoA. Okay, HMG-CoA. And then, okay, via the action of the HMG-CoA reductase, that eventually leads to formation of mevalonate. Okay, that eventually leads in the formation of mevalonate or mevalonic acid. So in the liver, there is a possibility, or not possibility, it really does. Okay, gumagawa talaga siya ng cholesterol de novo that is from acetyl-CoA. Via the synthase enzyme, there is HMG-CoA. And via reductase, there is mevalonate. Once mevalonate is formed, tuloy-tuloy na ang mga processes that would eventually lead to cholesterol formation. Okay, that would eventually lead to cholesterol formation. So that is the pathway, a simplistic pathway de novo, involving de novo cholesterol biosynthesis. Okay. Additionally, please note that the liver produces cholesterol de novo at night. Okay? It really peaks at night. So tuwing gabi siya nagiging at peak. Okay? So marami nagagawang cholesterol tuwing gabi. So the importance of stating this, that is because we have drugs available in the market that targets this cholesterol biosynthesis. And may kinalaman siya doon sa pag-inom tuwing gabi. So mamaya madidiscuss natin yon. Okay? So imagine we have excess or we have cholesterol being produced by the liver, plus from the food that we eat. So if not managed, or if not monitored properly, that could result to excess cholesterol level. Kaya nga, pwede magkaroon ng atherosclerotic plaque formation. Kaya we really need to monitor the level of cholesterol in someone's body. Okay? Next, eto guys, no need to study this. Ang point ko lang dito is, important ang cholesterol for certain processes like steroid hormone production, stability ng cell membrane, and bile acid synthesis. Yun lang siya. Nabanggit ko na siya lahat kanina. Okay? Ang point lang dito is, saan napupunta yung cholesterol na dala-dala ng LDL. Okay? Yan yung ibig sabihin yan. And then finally, since na-discuss natin na steroid production, cell membrane stability, and bile acid synthesis, related to the action of one of the drugs na i-discuss natin, ay may kinalaman sa bile acid utilization. So with that, i-discuss natin how the body utilizes bile acids. Although, may konti na kayong idea dito because we discussed this before sa org meds, I guess. So remember, ang bile acids ay galing sa cholesterol, okay? Galing sa cholesterol na ginagawa ng liver. So once cholesterol becomes bile acids or bile salts, ano usually ang nagiging fate niya? Okay? Ano usually nagiging fate? So usually, ang bile salts na ginawa ng liver ay mapupunta into the small intestine, which is initially iisipin natin meant siya for excretion ultimately. Okay? However, pag nakarating na siya sa terminal ileum, out of 100%, okay, again, out of 100% ng bile acid na nandyan, 5% lang ang pupunta sa colon. Okay? 5% lang ang pupunta sa colon. Question, pag napunta sa colon, anong ina-expect natin? Is it reabsorbed or excreted? Okay, so ina-expect natin na yung 5% ay ma-excrete. But 95% will be reabsorbed by the small intestine. Kaya nakalagay dyan, 95% of the bile salts are being reabsorbed by the small intestine. That is the process called biliary recycling. Again, ang tawag doon ay biliary recycling. So 95% of the bile found in the intestine will be recycled, will be reabsorbed. That's why you can see here that through the hepatic portal vein, yung 95% ng bile acid ay babalik sa liver and then i-store siya into the gallbladder. Okay, store siya into the gallbladder. Kaya ang gallbladder is the one that stores bile acid. But the one that produces is the liver. Okay? Si liver ang gumagawa, si gallbladder ang nag-store. So if in case merong another round ng bile acid excretion, ang gagawin na lang would be the liver again. For example, meron tayong another round of bile acid excretion. Ang gagawin na lang ng ating liver ay 5%. Okay, 5% na ang gagawin niya kasi yung 95% nga nakastore lang. Okay? And then, ilalabas ulit and then 5% ulit ang ilalabas ng katawan, i-excrete. And then majority, which is 95%, will be reabsorbed balik sa gallbladder. So, ganun ang nagiging direksyon ng bile acids. Majority is being recycled. Okay? 95% of it. So, that's the fate of bile acid. You should remember this because may gamot din tayo na ina-alter yung quantity na yan. So ang gagawin ng gamot na i-discuss natin mamaya, pwede niyang baliktarin yung amount ng ine-excrete at amount ng nire-reabsorb. Meron siyang clinical value, of course. Okay? So overall, that's the end of physiology of handling lipids and also implications when there is excess cholesterol. Next. Can we continue? Okay, so let's continue. So since ang topic natin is all about dyslipidemia, let's define it. Dyslipidemia refers to the condition of abnormal lipid levels in the bloodstream, in the bloodstream or in the systemic circulation. And this serves as a major risk for coronary artery or coronary heart disease. So na-explain na natin, when there is excess lipids like cholesterol, that could lead to obstruction in the coronary arteries. Now, ang hyper or ang dyslipidemia ay abnormality. And this is also known as hyperlipoproteinemias. General term siya when there are problems or metabolic disorders involving elevations in lipoprotein species. You have to note that the term hyperlipidemia or hyperlipoproteinemia is different to hyperlipemia. Usually kapag hyperlipemia lang ang term, it focuses on triglyceride levels. So pag ang mataas ay triglyceride, pwede siyang tawaging hyperlipemia or basically hypertriglyceridemia. Ay parehas lang yun. So we have two major classes of hyperlipidemia or causes. So we have primary, meaning genetic defect siya, unknown ang specific cause. Para siyang sa hypertension. So pag primary, you cannot actually determine the major cause. And then pag secondary, meron siyang underlying specific problem. So usually, ito ay may kinalaman sa metabolic disorder. Halimbawa, if a patient has diabetes mellitus, usually associated na rin siya sa hyperlipidemia. Okay? Associated na rin with hyperlipidemia. So related sa ibang metabolic diseases like diabetes. So we said that excess fats like cholesterol could cause atherosclerotic plaque formation. So na-discuss natin through that process, through oxidation of lipid-laden macrophages that could make the arteries rigid. So ito yon, making atheromas. So atheromas, ibig sabihin yan, degenerative walls of the arteries. Okay? So again, atheromas, this means degeneration of arterial walls. A degeneration of arterial walls. And may idea na kayo what could happen. Like for instance, that could lead to hypertension and also very important risk factor ang hyperlipidemia sa development ng coronary artery disease. Remember, in coronary artery disease, that could lead to ischemia or infarction. And do you think that could lead to heart attack or myocardial infarction? Yes, that could lead to myocardial infarction, which is fatal to the patient. So coronary artery disease, na-discuss na natin siya last time. And then one of the major risk factor is hyperlipidemia. Kaya we really need to monitor the level of lipids in person's body kasi if not, that could lead to complications like CAD and other cardiovascular diseases. Not to mention that risk factors also are hypertension, smoking, yes, smoking, overweight or obesity, and then sedentary lifestyle. So if you will not engage yourselves to rigorous physical activities, that could eventually lead to increase in lipid levels. Kaya lalo na ngayong lockdown, very important na you try your best or you do your best to engage yourselves to physical activities. Kahit 30 minutes lang per day, mag-brisk walking kayo, mag-unat-unat kayo, o kaya manood kayo sa internet ng mga konting mga galaw-galaw kasi kapag nakaupo lang tayo lagi, eventually pwede mag-develop siya. Okay? Minsan hindi na pinipili ang edad para mag-develop yung mga ganitong klaseng conditions. Alam nyo ba, isa sa, ipopost ko yung recording saglit na kwento lang. Actually, alright, so based on the guidelines, this is the recent guideline established by the National Cholesterol Education Program. And this determines if the cholesterol level of a person is normal, borderline, high, or low. So don't worry, I'm just having this figure or table. Huwag nyo nang i-memorize to kasi clinical pharmacy. May clinical pharmacy kayo ngayong SEM, di ba? Anong block ang Clean Pharm nyo? So sa Clean Pharm, madi-discuss yung mga guidelines and then dun sa inyo papakabisa yan. Kaya I'll just leave these values to clinical pharmacy subject. I'm just having the recent guidelines, okay, established by the National Cholesterol Education. So moving forward, let's proceed on the therapeutic strategies in the management of hyperlipidemias, particularly secondary. Remember, ang secondary, ito ay linked sa lifestyle. Okay, linked sa lifestyle. And this is caused by specific problems or specific diseases like diabetes. So meron tayong dalawang approaches. It could be non-drug or non-pharmacologic lifestyle modification sa madaling salita. Number one, dietary restriction of cholesterol and also lipids. So you control eating meals na masyado mataas ang cholesterol levels, lalong-lalo na kung alam niyo sa sarili niyo na limited ang movement niyo. Okay? Second, we have dietary restriction of sugar because as I've said, studies have shown that increase in sugar levels is correlated to increased plasma lipid levels. Kaya nga patients with diabetes are often linked to having hyperlipidemia as well. And then cessation of smoking because one of the primary risk factors based on studies is smoking. And sa drug therapy, kung hindi na kaya magbago or hindi na kaya lang ng pagbabagong buhay, kailangan magsama na ng gamot. So drug therapy. Since we are talking here on pharmacology, we will focus on the pharmacologic intervention by using anti-hyperlipidemic drugs. So the major goal of hyperlipidemic drugs is in the prevention ultimately of myocardial infarction. Ang myocardial infarction is fatal to the patient. Nag-ugat ang MI because of infarction na dahil sa coronary artery disease. Ano ba ang major cause ng coronary artery disease? Atherosclerosis, right? And then ang atherosclerosis galing siya sa excess cholesterol or excess lipids. That's why we are using anti-hyperlipidemic drugs para eventually mapigilan ang MI by the following actions. Number one, to decrease production of lipoproteins because decreased lipoprotein levels could also mean decrease in lipid levels because the proteins carry the lipids. Second is to increase catabolism of lipoprotein. Ibig sabihin ng increased catabolism, ang goal dyan is to enhance hydrolysis of lipoproteins, particularly yung triglyceride component. And then finally, to increase removal of cholesterol from the body. Take note that the process of removing cholesterol is through pagdumi or pagdefecate, okay? Bowel movement. And the form of cholesterol na ina-excrete ng katawan natin is in the form of bile acid, okay? Bile acid. Kaya lang, normally, majority ng bile acid ay na-excrete ba o nare-reabsorb? Normally, anong nangyayari usually? Na-excrete o nare-reabsorb, very good nare-reabsorb. Kaya isang goal ng gamot, baliktarin yung sitwasyon. That is, imbes na marami ang ma-reabsorb, marami dapat ang mailabas. Kasi pag marami ka nilabas na bile acid, marami ka rin nilalabas na cholesterol. Okay? So these are the ways on how to prevent MI by using lipid-lowering agents. With that, let us discuss the different groups of hyperlipidemics, beginning with HMG-CoA reductase inhibitors until Probucol. First, we have the HMG-CoA reductase inhibitors. Regarding HMG-CoA reductase inhibitors, basically, ang tawag sa kanila, statins, ay statins because on their names, nag-e-end ang pangalan nila sa statin. Now, amongst these examples, ang dalawang nasa dulo, sila lang ang mga long-acting statins. Okay, again, sila lang ang mga long-acting statins. For instance, ang half-life ng atorvastatin ay 14 hours. This is quite long. And ang longest ang half-life ay rosuvastatin. Again, atorvastatin has a half-life of 14 hours. And then rosuvastatin, we have 19 hours. So, matagal siya. Unlike nung tatlo or other, kahit anong statins na natira, bukod sa ator at rosu, lahat ng natira, short-acting lang sila. Ay short-acting. That is, short-acting 1 to 3 hours lang ang duration or ang half-lives sila. Again, ang half-lives. Again, short-acting statins, 1 to 3 hours. Please remember these half-lives because may implications sila sa time of administration. So regarding HMG-CoA reductase inhibitors or statins, take note that the MOA of statins is to block, again that is to block the enzyme called HMG-CoA reductase. Okay, they block this enzyme. So inhibition of HMG-CoA reductase would prevent de novo cholesterol synthesis. Di ba diniscuss natin ito, which happens in the liver. Okay, which happens in the liver. So anong pwede mangyari? Pag na-block ang HMG-CoA, no mevalonate formation, kaya ultimately, no cholesterol formation. Kaya by using statins, they block cholesterol synthesis de novo, resulting to decreased cholesterol levels. Okay, resulting to decreased cholesterol levels. Now, how can we relate this action to the half-lives that I discussed earlier? Natatandaan ba kung tuwing kailan yung peak ng de novo production? Umaga, gabi? Naalala nyo ba yung kanina? Yes. So, ang peak ng production ay gabi. So, therefore, kung gabi siya, nagmamatter yung oras ng pag-inom mo ng statins. That's why, siguro natutunan nyo to before, ang usual advice ng pharmacist kapag ang tao ay iinom ng statin, take the drug at night. Okay? Take the drug at night. Because the enzyme that is responsible for the production is active, fully active at night. So try to imagine, if you take lovastatin, halimbawa, you take lovastatin at 8 a.m. in the morning. Pagsapit ng 11 to 2 p.m., 11 to 2 p.m., ubos na yung lovastatin sa katawan. So sa ganitong oras lang siya active. Pagdating ng gabi, hindi na. So makakagawa pa rin ng cholesterol. Kaya gagamitin mo ang short-acting tuwing gabi. Okay? Tuwing gabi. Nagets ba yung time of use? Okay, good. Whereas, ang Ator at Rosu, ito yung exception to the rule. Pero ang advice pa rin ng pharmacist in general, take at night. Pero technically, pwede silang any time of the day. Inumin mo na umaga, okay lang. Kasi pagdating ng gabi, active pa rin against the enzyme. Okay? Take the drug any time of the day. So that's the mechanism of action of statins. So let's proceed on the different pharmacologic properties of statins based on the MOA. Anong mangyayari kapag gumamit ng statin at binlock ang cholesterol production? Take note, number one, statins by reducing cholesterol levels, it is expected that LDL level will also be reduced. Okay? So bababa din ang LDL level. Bakit? Ano bang kinikerry ng LDL? Ang kinikerry ng LDL ay cholesterol. So common sense, pag kumonte ang dadalhin, konti ang magdadala. Ulit, pag konti ang dadalhin, pag konti ang cholesterol, konti ang magdadala. Kaya reduced cholesterol also means less serum, serum or blood LDL levels. Lalo na kapag sinamahan or in combination with other hypolipidemics. And as I've said, in general, it should be given at night if to be given a single dose, except Rosu and Ator. Naintindihan na bakit except ang Ator at Rosu? Ha? Okay. Kaya lang, syempre, along with the advantage of taking it any time of the day, syempre, kasama ang presyo doon. Pag tinignan nyo ang mga prices ng statin, sobrang mahal ng Ator at Rosu. If observant kayo or pa nag-internship kayo, makikita nyo, okay? Mahal yan. Or sa mga merong magulang or kakilala na nagte-take ng Lipitor is atorvastatin, mahal siya, okay? Rosu is Crestor, mahal din siya. Actually, mahal talaga siya. Next, absorption, in general, absorption is enhanced by food. Kaya usually sinasabi ito sa pasyente na inumin after meals para may laman na pagkain yung sikmura ng patient. But hindi kasali ang pravastatin. And amongst the statins, the most efficacious agent is rosuvastatin. Okay? Next, what are the effects caused by using statins? Number one, on lipid levels. As I've said, these agents can reduce cholesterol synthesis, thus lowering LDL levels. Okay, lowering LDL levels. What else? What else? Isa pang effect ng mga statins is that they upregulate. Pag sinabing in-upregulate, dumarami ang expression. Again, there is increased expression of LDL receptors into the hepatocytes. Again, there is increased expression of LDL receptors into the hepatocytes. Question, isa ba sa destiny of fate ng LDL, pumapasok ba siya sa liver for bile acid production? Yes or no? Yes. So come to think of it, for example, this is the serum or the blood, let's say. Halimbawa, this is the blood and this is the liver. Ibig sabihin, guys, nung portion na ito, yung binibilugan ko, ibig sabihin yan, yung LDL mula sa blood, dumadami ang pasok sa liver. Dumadami. Bakit dumadami ang pasok sa liver? Kasi yung receptor, dumadami din. So pag maraming receptor sa liver for LDL, maraming interaction, kaya eventually ma-endocytose siya o makakapasok. So with that being said, what will happen then to blood cholesterol or blood LDL? Tumataas o bumababa using statins? Kung pumapasok sa liver, ano nangyayari sa blood cholesterol? Taas o baba? Baba, very good. So that's why these agents, statins, can really lower blood LDL levels. Okay? So bumababa kasi pinapapasok sa liver. Next, in terms of altering triglyceride levels, only modest lang siya. And then, merong small increase in HDL. So, statins can increase HDL but not that high as compared to the others. So, for the clinical uses, number one, first-line agent ang statins for hypercholesterolemia. Okay, again, first line in the management of hypercholesterolemia and also necessary in the management or in the prevention of atherosclerotic plaque formation. So stabilization of atherosclerotic plaque during CAD. And then we have adverse effects. Toxicities caused by using or brought about by using HMG-CoA reductase inhibitors are the following. Number one, these agents are potentially hepatotoxic. Okay, so these agents are potentially hepatotoxic. That's why kapag nagte-take ng statins ang patient for long-term therapy, important na mag-conduct ng liver function test determination. Okay? Conduct liver function test determination like measuring ALT and AST of patients. Again, like measuring ALT and AST of the patient. Ang ALT at AST ay determinant ng liver function. Pag mataas ito sa tao, ibig sabihin, meron kang suspected liver disease. Okay? Meron kang suspected liver disease. So, ang ginagawa sa hepatic dysfunction or sa liver function test determination, ang ginagawa dyan is minimeasure ang baseline, and then during therapy. Okay? During therapy. Pag sinabi nating baseline, before taking the statin, okay? Before taking, i-measure. Okay? I-measure ang level. So, for example, nag-measure ng certain or na-measure ang value ng ALT at AST ay meron tayong certain variable. And then, during statin therapy, tumaas siya. Tumaas than the baseline. Tandaan, pag tumaas siya than the baseline, this serves as an evidence na dahil kay statin, tumaas ang ALT at AST, signifying liver problem. Okay? Kapag hindi tayo nag-conduct ng liver function test, we will never know kung ang statin ba ay hepatotoxic na sa tao. Unless naging symptomatic na siya sa tao. Like naninilaw na siya, parang ganon. Pero hanggat wala, importante na alamin ang AST at ALT ng patient. Okay? So paano pag tumaas? Modify the dose. Or if worse talaga ang nangyari, stop using statins and shift into using other agents. Okay? So yan ang unang effect. Conduct liver function test determination. Gets? So kailangan ng baseline and then during para malaman kung nagbago. Next, ang mga statins ay myotoxics as well. Myotoxic meaning they can target the muscles causing muscle pain, myositis, or even worse, rhabdomyolysis. In rhabdomyolysis, there is breaking down of the skeletal muscle, a breaking down of the skeletal muscles, and then accompanied by rhabdomyolysis are hyperkalemia, a hyper accompanied by this are hyperkalemia and also acute renal failure. So because of rhabdomyolysis, patient could also suffer from hyperkalemia and acute renal failure. So yung breaking down of skeletal muscles, lumiliit ang size ng skeletal muscles, and then ang potassium stores or yung pool of potassium sa skeletal muscle pupunta sa blood. And then eventually maglilid sa acute renal failure. And then HMG-CoA reductase inhibitors could also interact with enzyme inhibitors or with cytochrome inhibitors that could enhance toxic effects of statins. And then finally, statins are teratogens, meaning pwede siya mag-cause ng adverse growth sa mga fetus. That's why it should not be given to women who are pregnant, lactating, and also expectant mothers. In fact, ang rosuvastatin is FDA Category X. Ang FDA Category X, ibig sabihin, may proven studies na adverse siya sa baby, sa buntis, at sa animals. Okay? So yan ang adverse effects and contraindications of statins. Okay. So before we proceed on bile acid sequestrants, let us have a health break, 5 minutes. So please be back at 8:42 and then continue tayo. Mabilis na itong mga susunod, yung mga actions sila. Okay, so see you later, 5 minutes. Again, let's proceed to bile acid binding resins. Bile acid binding resins are also known as bile acid sequestrants. Okay, these are bile acid sequestrants. The following are the examples of bile acid sequestrants. Number 1, we have cholestyramine. Second is cholestypol. And finally, we have cholesevelam. So what are the properties of these resins at bakit nila napapababa ang cholesterol levels inside the body? Okay? Number 1, sulat natin dito. Number 1, take note, ang bile acid binding resins, these are non-absorbable. Okay? These are non-absorbable drugs or non-absorbed agents. So when we say non-absorbed drugs, ibig sabihin yan, when a patient takes a bile acid binding resins, dadaan lang yung drug sa GI tract, dadaan lang siya sa GI tract, and then i-excrete na siya agad, idudumi na siya. Okay, idudumi na siya. Hindi na siya papasok sa bloodstream. It will not enter into the bloodstream. It will not be distributed. Instead, pasok sa bibig, labas sa anus. Ganun lang ang pagdadaanan ng bile acid binding resins. Ngayon, ito ang plot twist sa kanya. Isipin natin na ang bile acid binding resins ay parang magnet. Ay parang magnet sa ating katawan. Ibig sabihin, pag tinake mo by mouth ang bile acid sequestrant at pag dumaan siya sa GI tract, kung sino man ang dumikit sa kanya, again, kung sino man ang dumikit sa kanya, hindi na rin maa-absorb. So that's why, whatever happens to the bile acid sequestrant, ganun din ang mangyayari, ganun din ang magiging kapalaran nung na-magnet sa kanya o dumikit sa kanya. That is, daan sa GI tract, idudumi na. Tapos, ay ganun ang mangyayari. Now, isang pwedeng dumikit o mamagnet sa bile acid sequestrant ay ang bile acid. Okay? Ang isang pwedeng dumikit ay bile acid. Kaya nga ang tawag ay bile acid binding resin or sequestrants of bile acids. Okay? Nasusundan so far? Okay. Now, ano bang natatandaan about bile acids? Remember, ang bile acids ay saan gawa ang bile acids? Gawa ito sa cholesterol. Ginagawa ito actually ng liver. Okay, ginagawa ng liver. Now, ang bile acid, remember, bile acids, majority of the bile acids are being reabsorbed. Okay, are being reabsorbed. And then, only 5% is being excreted. So imagine, if a patient uses bile acid sequestrant at dumikit ang bile acid sa gamot na ine-excrete, mababaliktad ang mangyayari. So that is, pag gumamit ka ng sequestrants, imbes na may biliary recycling, mai-inhibit ang biliary, okay, mai-inhibit ang biliary recycling. Okay, mai-inhibit ang biliary recycling. So pag na-inhibit ang biliary recycling, yung 95%, anong ibig sabihin? Reabsorb or excreted pag gumamit ka ng gamot? Yes, very good. So 95% ang ma-excrete. Okay, 95% ang ma-excrete. So, anong pwede mangyari kapag 95% ang na-excrete? Will the liver synthesize more bile acids? Yes or no? Will the liver produce more bile acids? Yes or no? O sige, i-guide ko kayo ha. Mamaya i-discuss natin yon. Ang sagot ay yes. Ang sagot ay yes. So mamaya i-discuss ko kung paano yun nangyayari. Okay? So sa ngayon, ito muna. So 95% are being excreted. Okay? 95% ay na-excrete. That's why bumababa ang cholesterol levels. Okay? Bumababa ang cholesterol sa tao kasi dinudumi, nilalabas lahat. Okay? O balik tayo dun sa question ko na bakit yes ang sagot dun sa synthesize more bile acid? Let us have this figure. Okay? Let us have this figure. So remember, the liver produces the bile acid from cholesterol. So let's have this illustration. So we have conversion of cholesterol into bile acid. And then sabi nga natin, normally na re-reabsorb. So pag gumamit ka ng bile acid binding resins, majority ng bile acid made up of cholesterol will be excreted. So 5% lang ang babalik sa gallbladder. So magtataka ang liver. Sasabihin ng liver halimbawa, oh bakit ang konti nang bumalik? And normally 95%. So that gives the liver the signal na gumawa pa ng bile acid kasi nakita niya konti ang bumalik eh. So ibig sabihin, okay, sige, gagawa ako. So gagawa ang liver ng 95% ng bile acid. Gagawa siya. So the liver produces 95% bile acid. Question, kung gagawa siya ng 95% na bile acid, does it require more cholesterol as raw material? Yes or no? Will it need more cholesterol pag gagawa siya ng bile acid? Yes. So ang effect nun is increased cholesterol requirement. Pag sinabi requirement, kakailanganin. Kakailanganin. So imagine ulit, kapag nangailangan siya ng mas maraming cholesterol, ang tendency, gagawa siya ng cholesterol, pero tinatapon nga lang siya. Tinatapon. Kaya darating ang time, mauubusan ang liver ng supply ng cholesterol. Kaya sa dulo, ang effect niya, bumababa ang cholesterol levels. Okay, bumababa. Kasi nagtataka siya, bakit ang konti nang bumabalik? Yung pala, iniiwan na siya. Okay? Tinatain na o dinudumi na siya. That's why that would result ultimately to reduction of cholesterol levels. So yan ang mechanism of action ng bile acid sequestrants. O recall tayo, recall. Ang bile acid sequestrants ba ay absorb or non-absorb? None. Do they enter the blood? Yes or no? No. Very good. So pag dumikit, excreted or absorbed sa sequestrant? Excreted. Very good. That's why nai-inhibit ang biliary recycling. Okay? Now, sa tatlong mga examples ng bile acid sequestrants, distinct ang cholesevelam. Because on top of its hypolipidemic effect, ang cholesevelam also, it is used in the management of diabetes mellitus type 2. Okay, type 2. It's not effective for type 1, but for type 2 only. Okay? But the specific or exact mechanism of action of cholesevelam is still unknown for type 2 diabetes. But the evidence suggests that it can alter the level of glucose in patients with type 2 diabetes mellitus. Okay? Siya lang. Hindi kasali si cholestyramine at cholesterol. Siya ay si cholesevelam lang. Okay? Next, clinical uses of bile acid binding resins. Since these agents can lower cholesterol and LDL levels by enhancing excretion, they can be used in the management of primary hypercholesterolemia and add on to statins. Okay? Add on to statins, meaning pandagdag to statins in the management of secondary hypercholesterolemia. And these agents potentially can increase HDL, triglycerides, and also VLDL. So in this case, it can be used in combination with niacin if used to treat patients with LDL elevations and with combined hyperlipidemia. Okay, they can it must be decrease. Okay, it must be decrease triglyceride VLDL, and then HDL is being increased. Okay, so kindly modify. So they decrease triglycerides and VLDL but increase HDL levels. So they are being combined also to niacin. Niacin is another example of hypocholesterolemic agent na i-discuss natin mamaya. Okay, or hypotriglyceridemic agent. Next, these agents can also be used in relieving pruritus in patients with bile salt accumulation. Note everyone, although mechanism is still unknown, patients with bile acid accumulation in the body suffer from pruritus. Okay? So isa sa mga simptomas na mataas ang bile acid sa katawan ng tao is nangangate. Ay nangangati sila. And to be able to cause enhanced excretion of bile acid, we can use sequestrants. And finally, pwede silang gamiting antidote during digitalis toxicity. So these agents like cholestyramine and also cholestyramine, sila yung ginagamit for digitalis poisoning. What's the rationale? Ganun pa rin, non-absorbed. Diba? Magnet sila. Digoxin or digitalis can bind to the sequestrants. Therefore, may enhance natin ang excretion of digitalis. And enhancing excretion of digitalis could mean beneficial effects kasi we are preventing further absorption. Adverse effects. Siyempre, nakafocus sa GI tract lang ang adverse effects ng mga bile acid sequestrants. That's why there could be unpalatability, bloating effect in some cases, and constipation kasi non-absorb nga siya. And in some cases, although it is expected na bumababa ang triglyceride, there are tendencies that the drugs, cholestyramine, cholesevelam, and cholestyramine can increase triglycerides. Another, magnet sila, hindi ba? Kaya pwedeng hindi ma-absorb ang ADEC vitamins, which are fat-soluble vitamins, and then other drugs. So for example, vitamin K cannot be absorbed if taken together with bile acid sequestrants. So anong possible risk or possible repercussion dito? Kapag ang patient ay nagwa-warfarin therapy, di ba nagwa-warfarin therapy, tapos binigyan siya ng vitamin K pero may cholesterol, pwede magdugo yung patient kasi napapababa ng cholestyramine ang vitamin K level. Anong sabi natin sa pre-recorded lecture ko? Magkaaway ba ang warfarin at vitamin K? Yes. Kaya it can further cause bleeding. Okay? And then steatorrhea. Pag sinabing steatorrhea, fatty stool formation. Fatty stool, expected yon kasi kapag ikaw ay nagtitake ng cholestyramine, nakikita mo sa stool yung fat, okay? Nakikita mo doon yung bile acid made up of cholesterol. Kaya fatty ang stool. May taba, rich in taba yung stool, okay? And then cholesevelam is pregnancy category B, so that's why ginagamit siya in caution. Pwedeng gamitin pero dapat monitored. Not necessarily bawal, pwede pero dapat monitored in patients who are pregnant. Next, tapos na tayo sa sequestrants. So moving on, we have niacin. Niacin is actually vitamin B3 as everybody is aware of. But let me tell you that meron tayong dalawang forms ng niacin. Okay, meron tayong dalawang forms ng niacin. Number one is nicotinic acid. Okay, number one is nicotinic acid. And the second form of niacin is niacinamide. Again, there are two forms of niacin. These are nicotinic acid and the niacinamide. take note that between the two, the one that possesses hypolipidemic action is nicotinic acid. Okay? Siya yung nagpo-possess ng hypolipidemic action. Niacinamide is a form of B3 that does not induce hypolipidemic action. Kaya sa mga libro, makikita nyo na mas specific ang pangalan niya, it's nicotinic acid. So discuss natin ang mechanism of action, ay mechanism of action ng niacin. Okay, discuss natin. Number 1, ang action ng niacin is by inhibiting synthesis and also release of VLDL. Again, niacin can inhibit the synthesis process and also release of VLDL. Remember, ang VLDL nanggagaling saan? Sa liver o sa small intestine? Yes, it originates from the liver. So ang action ng nicotinic acid is in the liver by inhibiting the synthesis of VLDL. Pag sinabing inhibiting the synthesis, remember, di ba natatandaan nyo kanina, ang chylomicron remnants minimake over ng liver. Kino-convert ng liver ang remnants para maging VLDL. Di ba? Ini-improve niya yon. So ang ginagawa ng niacin, binablock niya yan. Okay, binablock. That's why, pag binlock mo ang synthesis ng VLDL, syempre, yung release, hindi na rin mangyayari kasi wala nagawa eh. Okay? Ano ba majority ang dala-dala ng VLDL? Triglycerides, right? Kaya ang effect of using nicotinic acid is it lowers triglyceride levels. Unlike ng statins kanina at ng sequestrants, cholesterol ang pinapababa nila. At etong niacin, more on triglycerides ang pinapababa. Okay? More on triglycerides. What else? Ito yung isang action ng niacin. Pangalawa, bali number 1 and then number 2, second action of nicotinic acid is by activating LPL. Again, it activates LPL. Remember that LPL is the enzyme that hydrolyzes triglycerides, right? Therefore, if there is enhanced activity by lipoprotein lipase, what would you expect? Greater or lesser catabolism of triglycerides? Greater or lesser catabolism. Pag sinabing catabolism, nagiging free fatty acid and triglyceride. Less or more free fatty acid formation. Very good. It's greater. It's more. Why? Di ba nabanggit ko, huwag kayo malilito ang lipoprotein lipase ay enzyme. Hydrolytic enzyme siya. Ang triglyceride ba ay na-hydrolyze ng LPL? Yes or no? Yes. Okay, na-hydrolyze siya. That's why, pag gumamit ka ng niacin at enhance ang LPL, napapababa din niya ang triglycerides. Okay? Napapababa din niya ang triglycerides. So yan usually ang action ng nicotinic acid or niacin. But aside from that, para mas maintindihan pa ito, let's refer on the succeeding figures. So una, let's say in this case, remember that ang ginagawa ng hepatocyte, again, ang ginagawa ng hepatocyte or ng liver is that yung chylomicron remnants ay i-make over nga niya together with cholesterol para maging VLDL siya na merong apoprotein B100 or apoprotein B, di ba? Na-discuss natin. So may nakalagay ditong block, pinipigilan niya. Kaya nga, niacin inhibits synthesis and release of VLDL. Okay? That's why there is decreased LDL as well, but not as much as compared to statins and also bile acid sequestrants. And also, niacin can increase HDL level. In fact, ang niacin has the ability to increase HDL level at the most or at the highest extent. So amongst the hypolipidemic drugs, siya ang pinakamagaling magpataas ng HDL, which is a good thing kasi HDL wipes out cholesterol. in the arteries. Another figure that explains the MOA of nicotinic acid, doon muna tayo sa left side. Dalawang actions kasi ito eh. Okay? Sa left side muna tayo. So niacin can decrease adipose tissue fatty acid mobilization and therefore decreasing triglyceride synthesis. So para hindi kayo mahirapan dito, ang pinakamadaling way to remember is napapababa niya ang triglyceride synthesis by enhancing lipoprotein lipase activity and inhibiting synthesis and release of VLDL. Okay? Next, on the right side. Ang right side naman, this talks about the action of niacin in increasing HDL levels. What does niacin do? It lowers catabolism of HDL receptors. In other words, the degradation of HDL receptors nalilesen ni niacin, napapababa niya. Kaya ang effect ng niacin is it reduces HDL clearance. Okay? It reduces HDL clearance. Again, it reduces HDL clearance. Pag sinabing reduces HDL clearance, yung turnover mabagal, kaya tumataas sa katawan. Okay? Next figure. O, ganun din ito guys, ganun din ito. So kapag gumamit ng niacin ang patient, bumababa ang triglyceride inside the liver, and less triglyceride would mean less makeover for the remnants of chylomicrons. And less makeover would also mean reduce VLDL levels. Kaya reduce VLDL levels na available sa bloodstream. Kaya meron dito decrease serum VLDL, and then napapataas niya ang HDL levels. Pero anong sabi ko? May kinalaman sa catabolism, not synthesis. Okay? May kinalaman sa catabolism, not synthesis. With that, napapabagal niya ang turnover o pagkasira ng HDL, pero yung production, wala siyang kinalaman doon. Kaya nakalagay dyan, not reduced synthesis. Okay, so recap tayo sa nicotinic acid. Again, recap tayo. Ang nicotinic acid, saan majority ang action niya? Towards cholesterol or triglycerides? TG, very good. So sa triglycerides. Number 1, it targets VLDL production and also release. And then second, activates lipoprotein lipase. Okay? So it also alters the activity of lipoprotein lipase by enhancing the action. And then, siya rin ang nag-iisang hypolipidemic na nagpapataas significantly ng HDL, pinakamataas in fact. And that is because of reduced clearance, not enhanced synthesis. Therapeutic uses. Alternative drug ang nicotinic acid to fibrates. Later we will discuss fibrates for hypertriglyceridemia, and also the most effective agent in increasing HDL. Okay, again, most effective agent in increasing HDL, I told you na ang reason is reduced clearance. And also, it is the drug that is used in patients with increased lipoprotein A levels. Ang lipoprotein A is also correlated to coronary artery disease. So if a patient has increased lipoprotein A, usually ang binibigay na drug sa kanya ay nicotinic acid because that's the only drug that reduces lipoprotein A. Next are the adverse effects of nicotinic acid. Toxic effects are the following. Number 1 is flushing. Flushing means redness, okay? Harmless cutaneous vasodilation. I repeat that flushing is redness o namumula yung patient. Using nicotinic acid can cause redness. Now, kung tutuusin, that is harmless or wala naman siyang masamang effect sa tao. But if the patient feels uncomfortable na namumula siya, we can actually counteract this adverse effect. Mind you that redness is prostaglandin mediated. Ibig sabihin, may production ng prostaglandin kaya nagkaka-redness. So to be able to counteract that, we can use an agent that would block prostaglandin synthesis. Siyempre gagamit ng NSAIDs. Di ba ang NSAIDs ay taga-block ng COX? Di ba taga-block sila ng COX? So COX inhibitors sila, thus preventing prostaglandin formation. That's why ang ginagamit natin ay aspirin, which is the prototype COX inhibitor. Okay, prototype COX inhibitor siya. What else? Ibuprofen also is effective. It is also an NSAID. And then, another adverse effect of nicotinic acid is GI disturbance, palpitations which are rare, and can cause liver disorders, impaired glucose tolerance, and also other metabolic diseases like gout. So this is the pharmacology of nicotinic acid. Going back so far, nakakatatlong groups na tayo, starting with statins, next, sequestrants, nicotinic acid. Number 4 are the fibrates. So yung common name sa kanila ay fibrates or fibric acid derivatives. Examples are gemfibrozil, clofibrate, fenofibrate, bezafibrate, and ciprofibrate. Regarding the mechanism of action of fibrates, medyo complex ang MOA nila. Okay? So isa-isahin natin. Number one, these agents can inhibit triglyceride synthesis and they can reduce VLDL release. So somehow, if you will check this, may kinalaman ito sa MOA ng nicotinic acid kanina. Okay? Meron siyang connection sa action ng nicotinic acid. But, ang activity ng fibrates sa ganitong action, sa ganitong MOA, ay may kinalaman sa pag-interact nila sa receptors called PPAR alpha. Okay? So this action is caused by activating PPAR alpha receptors. Meron tayong specific slide in discussing PPAR alpha receptors. Another action of, so iwan nyo muna tong part na to, okay? Meron tayong separate slide dyan. Another action of fibrates, they can enhance lipoprotein lipase activity. Remember, for the nth time, ang lipoprotein lipase ang nagme-metabolize ng triglyceride component. And you remembered last time or kanina that VLDL and chylomicrons, they carry triglycerides at the highest level, di ba? Kaya enhance ang catabolism ng VLDL and chylomicrons using fibrates because of enhanced lipase activity. And then, they can also increase catabolism of triglyceride-rich, o ito rin yung sinabi ko kanina, and also lowering serum VLDL. Yan yung diniscuss ko a while ago. So ngayon, focus tayo sa PPAR alpha. Ang PPAR alpha ay highly concentrated sa liver. Okay? And PPAR stands for peroxisome proliferator activated receptor. Now, pag na-activate ito, agonist ang mga fibrates ng PPAR alpha, ha? Agonists sila. Therefore, kung ano man ang effect ng PPAR alpha activation, that happens with the use of fibrates. So that's why we will discuss what's gonna happen. Take note, pag na-activate ang PPAR alpha, that could modulate the expression of several apoproteins. Okay? Importante ba ang apoprotein as components ng lipoproteins? Importante ba yon? Yes. Di ba important sila? So dito, ma-encounter natin anong klaseng apoprotein ang babaguhin ng PPAR alpha. Di ba sabi natin, may mga certain terms tayo sa apoprotein kada type ng lipoprotein. Dito natin yon i-apply. Number 1, through modulation of these apoproteins, PPAR alpha can upregulate LPL. Di ba ang LPL, as you recall, that can enhance metabolism of triglyceride component ng VLDL at chylomicrons. Pangalawa, ina-upregulate, ine-enhance din niya ang expression ng ApoA1 at ApoA2. Tanong, sa anong klaseng lipoprotein makikita ang ApoA1 at ApoA2? Hanap sa mga nakaraang notes. Yes, very good. HDL. Sabi, upregulate. Question, kung upregulate, ano mangyayari? Marami kang APO1, APO2. So pag marami kang APO1, APO2, marami kang HDL. Okay, tataas ang HDL. Question, increasing HDL is good or bad? Good, because it lowers blood cholesterol. Okay, very good. It lowers blood cholesterol. Another, ang PPAR alpha ay mapaglarong receptor. Kasi bukod sa pag-upregulate, may mga certain proteins naman siya na dina-down-regulate. Okay, down-regulate. So pag sinabi nating down-regulate, again, pag sinabi nating down-regulate, ibig sabihin yan, less expression. Okay, less expression. So, anong mangyayari kapag na-down-regulate niya ang ApoC3? Ang ApoC3 at ApoB ay ApoB, naaalala nyo, ang ApoB 100 nakikita sa VLDL. Ay, VLDL. So therefore, kapag merong down-regulation ng ApoC3 at ApoB, ano mangyayari? Bababa ang VLDL. Bababa ang VLDL. Nasusundan? Nagets ba bakit bumaba ang VLDL? Kasi walang protein, walang magke-carry. So nonsense na dali yung yung triglycerides. Okay? So ang effect, anong nangyayari sa HDL? Itaas o baba? Sa HDL using fibrates, HDL taas. VLDL taas or baba? Okay, very good. So moving forward, ito okay na-discuss ko na to, di ba? Increase HDL through improve ApoA and ApoII synthesis. So another figure that explains the MOA, actually, repetitive na lang siya. These agents can increase HDL production. Pag HDL, up o down regulate ng apoprotein? Up-regulate. What are those? APO1 and APO2. Okay, yan yung distinct. And also, ApoB100 and ApoC3 reduced. Saan related yon? Related sa VLDL. Okay? What else? Anong nangyayari sa lipoprotein lipase using fibrates? Enhanced o reduced activity? Enhanced. Pag-enhance ang LPL activity, taas o baba ang triglyceride? Baba. Very good. So somehow, meron na kayong idea sa possible type ng question dito sa exam. So lalaruin kayo dito sa LDL, HDL, VLDL. Taas, baba lang siya. Kaya advice ko pag tinractice niyo yung effects ng mga gamot sa lipoproteins at sa enzyme, yun yung aralin nyo dito. Practicein nyo. Okay, taas, baba, up-regulate, down-regulate, and then a MOA, of course. And then, also we have this figure. Paulit-ulit lang siya, pero ganun lang din ang punto nitong lahat. Okay? So, reduce ApoC3 synthesis and ApoB100. So, that's why, anong related lipoprotein? VLDL. And then, APO1 and APO2, anong sabi natin? ApoA1 and ApoA2, HDL. Okay? Sa HDL, taas o baba? Taas. Okay, taas. And then, ang effect din is decreased triglyceride synthesis. Okay, decreased triglyceride synthesis. And then, decreased secretion. Question, ano nangyayari sa VLDL and chylomicrons kapag na-hydrolyze? Ano mangyayari pag enhanced hydrolysis? Bababa o tataas ang triglyceride component? O take 2, pag na-hydrolyze ang VLDL at chylomicron, ano mangyayari sa triglyceride levels nila? Taas o baba? Andiyan pa kayo? O, ulitin natin O, naiba lang ng question. O, ulitin natin. Pag sinabing hydrolysis, di ba ang gumagawa niyan lipoprotein lipase, di ba? Okay. So pag enhanced hydrolysis, ibig sabihin enhanced lipoprotein lipase activity. So ano mangyayari sa triglyceride level? Taas o baba? Baba. Okay, baba. Okay? Huwag kayo malilito sa salitang hydrolysis, sa salitang lipoprotein lipase activity, parehas lang yun. Therapeutic uses. These agents are considered first line in the management of hypertriglyceridemia. They are the first line. Okay, first line. Ang niacin or nicotinic acid yung alternative lang. Pero kung mapapansin nyo, medyo may resemblance sila sa MOA. But ang distinct sa fibrates, they are agonists at PPAR alpha receptors, kay PPAR alpha receptors. And then, lahat na may kinalaman sa triglycerides, we can use fibrates. Adverse effects, number 1, rhabdomyolysis, but rare. Kaya lang, if that happens, it could be severe. And then, there could also be development of gallstone formation, okay, bile stone formation, and then mild gastrointestinal symptoms. Next, we have ezetimibe. Okay, ezetimibe. Ezetimibe is the correct pronunciation here, not ezetimibe. So regarding ezetimibe, it selectively inhibits intestinal absorption by inhibiting Niemann-Pick C1 like 1 transporter. Okay, so ezetimibe inhibits intestinal absorption of phytosterols and cholesterol by blocking Niemann-Pick C1 like 1. Natatandaan ba ang NPC1L1? Were we able to discuss this? Yes. What's the importance of Niemann-Pick C1 like 1? Siya ang tulay para makapasok ang chylomicrons sa dugo, di ba? San ulit nang gagaling ang chylomicron? Sa liver o sa intestine? Yes, very good. Sa intestine or small intestine. Kaya nakalagay dyan, inhibits intestinal absorption. So this is effective in patients with hypercholesterolemia and also those with high levels of phytosterols in the body. Now, in clinical practice, usually ezetimibe is being combined with statins. Well, actually, ang combination ng statins and also ezetimibe ay functional in preventing absorption of cholesterol and preventing production of cholesterol. Okay? By having this dual mechanism, ang tendency, there is enhanced lowering of cholesterol level in the patient. Now, sino sa tingin nyo ang nag-a-address ng inhibiting production? Is it the statin or is it ezetimibe or ezetimibe rather? Sino yung nagtatarget ng production of cholesterol? Is it statin or ezetimibe? Ulit, okay, linawin natin. Pag sinabing production, ang Tagalog ba ng production ay paggawa? Paggawa? Yes. So ang paggawa ng cholesterol ay nangyayari sa liver, 'di ba? Sa liver. Naalala niyo yung de novo synthesis? Yes. Okay? So ang de novo synthesis ay nangyayari sa liver, so statins yun. Okay, statins. And then kababanggit lang natin, kaya nga small intestine yung drawing sa right side, oh. So absorption siya that is being covered by ezetimibe. Okay, ezetimibe. That's why it provides dual inhibition. And in the market, combination of ezetimibe and particularly simvastatin, okay, simvastatin has the brand name of Vytorin. So again, simvastatin plus ezetimibe combination is marketed under the brand name Vytorin. Adverse effects of ezetimibe to ha, number 1, myositis, but it's rare also, and low incidence of hepatic dysfunction as compared to the statins. And then finally, we have Probocol. Probocol is not commonly used, but for your information, Probocol can increase LDL degradation. Enhanced LDL degradation would mean less level of LDL containing cholesterol. That's why ang effect niya, it can decrease cholesterol level, LDL level. However, it can decrease also HDL. So that's the disadvantage of Probocol use. Okay? So if we will review the drugs that we discussed, we were able to finish them all. Na-discuss natin ang statins, sequestrants, nicotinic acid, fibrates, ezetimibe, and Probocol. So in some cases, combination drug therapy is being applied provided that these factors are being considered. Number 1, when VLDL levels are significantly increased, okay? Significantly increased during treatment of hypercholesterolemia with the use of bile acid sequestrants. Remember that bile acid sequestrants can increase VLDL levels in some situations. And then second, when LDL and VLDL levels are both elevated initially, And then when LDL or VLDL levels are not normalized with single agent, so that's the time that you will combine. For example, statin plus ezetimibe. For example, statin plus bile acid sequestrant. So pwede natin i-apply yun if monotherapy is not essential or not enough rather. Finally, when an elevated level of lipoprotein A, di ba meron tayong isang gamot na nagpapababa nito, that is nicotinic acid, or an HDL deficiency coexists in patients with hyperlipidemias. So the point here is we can give more than one hypolipidemic drug provided that any of these conditions are met. Okay, kapag na-met or na-meet or nakuha ng isang pasyente. Okay? Combination drug therapy will be applied more on clinical pharmacy. So ang goal natin sa pharmacology is for you to have basic knowledge about medications or drugs that you will apply later on. Okay? Overall, that marks the end of drugs for dyslipidemia.